Okay. Hello, dear friends. Today we are going to talk about hypertension or high blood pressure. Hypertension management and prevention essential. Comprehensive conclusion on hypertension, and it's a conclusion. No complete talk about hypertension, but it's a conclusion about hypertension or high blood pressure. Introduction and global burden of hypertension. Hypertension remains one of the most significant public health challenges worldwide, affecting an estimated 1.3 billion adults globally, as said WHO in 2023. Often termed the silent killer, hypertension frequently presents with no symptoms while progressively damaging vital organs. It's a very important note. The economic burden is staggering, with cardiovascular complications from uncontrolled hypertension costing healthcare system over $370 billion annually. The 2017 American College of Cardiology and American Heart Association guidelines redefined hypertension classifications. Normal BP, they said normal BP is systolic blood pressure below 120 and diastolic blood pressure below 80 millimeter Hg will consider normal blood pressure. Elevated BP will be systolic blood pressure between 120 to 129 and diastolic blood pressure below 80 millimeter Hg. We must consider that diastolic blood pressure is more important than systolic blood pressure. Stage 1 hypertension, blood pressure of 130 to 139 of systolic and 80 to 89 millimeter Hg of diastolic will be stage 1st hypertension. And stage 2 hypertension will be 140 to 90 millimeter Hg. Stage 2 hypertension will be 140 or above systolic and 90 or above diastolic blood pressure. Despite widespread awareness, only 44% of hypertensive patients achieve adequate control, as said Control Disease Centers in 2023, underscoring critical gaps in detection, treatment adherence, and therapeutic advancements. Pathophysiological mechanism. Hypertension develops through complex interaction between genetic predisposition and environmental factor, and we will explain it below. We have two types of hypertension, primary or essential and secondary hypertension. Primary or essential hypertension is 90 to 95% of cases, and there are some causes. Neurohormonal dysregulation, or because of our activation of the sympathetic nervous system and RAS system, or renin angiotensin aldosterone system. Endothelial dysfunction, and the causes reduction in nitric oxide bioavailability. Sodium sensitivity. Some patients are sensitive to sodium, particularly it's prevalent in the black population. And vascular remodeling will increase peripheral resistance, and it's cause to hypertension or the increase of blood pressure. And secondary hypertension is 5 to 10% of patients. We will explain the cause and some key diagnostic clues. Renal artery stenosis is 1 to 5% of secondary hypertension, is responsible for 1 to 5% of secondary hypertension, and key diagnostic clue will be abdominal bruit, flash pulmonary edema. Primary aldosteronism is 10 to 20% of resistant hypertension in secondary hypertension, and diagnostic clue will be hypokalemia, elevated aldosterone renin ratio. Pheochromocytoma is 0.1 to 0.6% responsible in secondary hypertension. And the diagnostic clue will be paroxysmal hypertension, headache, and diaphoresis. And OSA, or obstructive sleep apnea, is the first responsible for secondary hypertension. It's 30 to 50% of hypertensive cases. And key diagnostic clues will be daytime sunlessness. Neck circumference in these patients is more than 17 inches in men. Diagnostic approach. The gold standard for diagnosing hypertension is measuring blood pressure, and we must consider some points while taking the patient's blood pressure. First, patient must be in seated position after a 5-minute rest, and we must choose a proper cuff size for different patients, and the bladder of cuff must encircle more than 80% of arm circumference. And confirmatory readings must be more than 2 visits unless the patient has stage 2 hypertension in the first diagnosis. Advanced diagnosis. For advanced diagnosis, we need 24-hour ambulatory blood pressure monitoring, which can identify nocturnal hypertension, which is a very predictive risk for cardiovascular disease. Home BP monitoring must be more than 7 days or 1 week reading. The reading must be before breakfast or taking any type of medications, especially antihypertensive drugs. And biomarkers, some biomarkers like BNP protein will increase in cardiac strain if the patient has hypertension. And urinary albumin, if the patient has renal damage, will help for more diagnosis. Lifestyle modification. We must consider that lifestyle modifications are the first line of treatment in any patients, especially patients with hypertension. Strategy. DASH, or dietary approach to stop hypertension. It will reduce the BP 8 to 14 millimeter Hg, and it's grade A. In advanced level, it will be grade A. Sodium must be taken below 2.3 gram per day, and the BP reduction will be 2 to 8 millimeter Hg. And potassium intake must be more than 3.5 gram per day, and it will help to reduce the BP 4 to 5 millimeter Hg. And physical activity. We must prescribe to all patients with hypertension physical activity. Aerobic activity. If the patients do aerobic activities, it must be 40 minutes with moderate intensity, like brisk walking, and the patient must do it 5 times per week. Resistance training. If the patients do resistance training, it must be 2 times per week, and the patient must avoid Valsalva maneuvers. Yoga and meditation will help to reduce the patient's blood pressure because of reducing the stress-induced blood pressure spikes. Pharmacotherapy strategies. First-line agents by comorbidity. If the patient has diabetes mellitus, their preferred antihypertensive drugs will be ACE inhibitors or angiotensin receptor blocker, plus calcium channel blockers in diabetic patients. And the patient should be avoided of thiazide diuretics if his EFG or is below 30. CKD in chronic kidney disease, the patient's the preferred agent is ACE inhibitor or angiotensin receptor blocker, plus monitoring the patient's potassium. And the patients with chronic kidney disease should be avoided, or NSAIDs should be avoided, or NSAIDs. Heart failure. With the patients with heart failure, beta blockers or ARNI, which are combined antihypertensive drugs, will help to control the patient's blood pressure. And we must consider in patients with heart failure NSAIDs, also dehydroprotein calcium canals blockers should be avoided. Dosing considerations. Chlorothalidone 12.5 to 25 milligram will help for for controlling the patient's blood pressure, and evening dosing improves nocturnal blood pressure control. Resistant hypertension management. If their patient's hypertension is resistant, we must confirm stepwise approach. We must confirm adherence. Urinary drug metabolite testing should be done for the patient. Maximize diuretics like chlorothalidone, and we must add spironolactone 12.5 to 50 milligram. Device therapy, renal denervation will be helpful for the patient. And there are some novel agents. Aprocitentan, which is an endothelial antagonist, will help to 3 to 8 millimeter Ag, 3.8 millimeter Ag additional reductions, which showed in one trial study. And baxdrostat, which is one aldosterone synthesis inhibitor, which showed in one trial. It will be useful for controlling patients' blood pressure. In special populations, how we must control the blood pressure. In geriatric hypertension, frailty adjusted goals, systolic blood pressure should be 130 to 150 millimeter Hg based on functional status. We must keep in all patients, the baseline blood pressure is usually high, and we must keep systolic blood pressure between 130 to 150 based on functional status. Fall prevention, we must in geriatric hypertension, as we said, we must avoid excessive nighttime blood pressure drops. In pregnant patients, labetalol will be a good choice, and it's category C in FDA categorization, and we can use it at first line drug for patients with pregnancy. Methyl dopa is one of the good choice for patients with hypertension in pregnancy. It's category B, but it has some side effects, and we must consider this also. And nifedipine XL is category C, and it must be avoided in first trimester. Complication and organ protection in hypertensive emergencies. Organ damage. Encephalopathy. If the patient has encephalopathy, the first treatment line will be IV labetalol or nicardipine, and target BP reduction will be 25% in first hour if the patient has encephalopathy. Aortic dissection. In patients with aortic dissection, IV esmolol plus vasodilator is a good choice, and the target of BP reduction is systolic blood pressure below 120 within first 20 minutes. And in eclampsia, in patients with eclampsia, the treatment is magnesium sulfate plus labetalol, and the target BP is to decrease diastolic blood pressure below 105 millimeter Hg. You must consider that in patients with eclampsia, the diastolic blood pressure is important than systolic blood pressure. Chronic organ protection, kidneys. SGLT2 inhibitors will help to 40% reduction in ESRD or end-stage renal disease, and in brain, intensive BP control reduces dementia risk. Further directions: precision medicine, polygenic risk scores for early intervention, and renin profiling to guide drug selection. Conclusion and call to action. Hypertension management requires multidimensional strategies, population level salt reduction policies, public screening, in clinical individualized therapy guided by comorbidities and technological remote monitoring to improve adherence. Critical unmet needs: better medications for resistant hypertension, low-cost ABPM in resource-limited settings, and addressing disparities in hypertension control rates.